here is a split of some of the different types of burns that we see. This is, again, across the country, but it's similar at our institution as well. The primary percentage is from flame burns, scald being hot water, hot oil. I have a couple of patients who are burned with, like, from fryers. Contact burns would be hot objects, electrical burns, chemical burns, and then other. So a pretty wide distribution, but primarily flame and scald. I'm not going to go into too much detail here, but I wanted to highlight the different levels of severity for burn injuries. First degree is kind of what you think about for sunburns. So your skin turns red, can be a little painful, and this would be a pretty intense sunburn, but usually no scarring. It's only the epidermis, outer layer of skin. Then the superficial partial thickness gets into second degree. You can have more blistering. It's very, very painful, but still low to risk, moderate risk of scarring. With the deep partial thickness in second degree, usually it can be, so this is important to note, it can be painful, but it also can have a decreased sensation because it's burned through some of the nerves. So people maybe aren't feeling the intensity of the burn when they're, like, after they experience it. It usually requires surgery, often has scarring, and then the full thickness or third degree also, interestingly, like, has no sensation because they burn through the nerves there, and then always requires surgery and will have significant scarring. TBSA, I just wanted to quickly note, one, because it helps them determine the amount of fluid resuscitation and whether or not people need to be transferred to a burn center, but also as a health psychologist, when you're looking through some of the surgical notes or resident notes, you'll see these terms and think like, oh my gosh, what does that even mean? So TBSA is total body surface area, and they use this general graphic chart to determine the amount of body tissue that's been burned. And again, it will determine the intervention medically, but also it's helpful to know from our perspective in terms of the intensity, the coverage, the locations. So I pulled some locations of, or some examples, excuse me, of what I've seen on some of my patient charts. So this might be, like you'll see 10% TBSA, mixed depth, partial thickness, second degree, chemical burns to the bilateral upper extremities, chest, abdomen, lower left, or left lower extremities, back, and buttocks. So when you're reading the notes, this is where you find out where and how bad the burns are. Some additional statistics from ABA. Really, the most important thing here to notice is the survival rate is really high. So it's about 96 to 97%. And again, the causes, the place of occurrence listed there, but I wanted to highlight the survival rate because this gets into why having psychology involved is so important. So we've had these advances in medical treatment. Over the years, patients used to die from their burns, and now they've figured out ways to resuscitate them, to make sure that they're getting the surgical interventions that they need, the rehab interventions that they need, and patients are living through these injuries, but they're also experiencing increased rates of surgery, lots of disfigurement and potential physical impairment that can take a greater emotional toll on them and then increase their risk for PTSD, depression, chronic pain, interpersonal problems. So it used to be that the big focus of the research was obviously on how do we keep these people alive, but now across the burn community, things have shifted, not just recently, but over the last, I don't know, decade or so, in terms of how do we improve quality of life for these patients so that they're not just surviving, but they're thriving after their injuries. Rehabilitation concerns quality of life are greater focus, so you'll see a lot of information on like physical therapy interventions, occupational therapy interventions, but it's really a growing field for health psychologists. So if anybody has any interest in this, as you're in training, definitely thinking about ways that you could either find opportunities to do more related to burns or to look for internships, fellowships that may have some opportunities for either research or clinical work, because there's a lot that you can do. Here's a list of a bunch of different psychosocial needs for burn patients. So the distress can be loss related, so you could lose your home, you could lose your job if you're injured at work, at least temporarily, a loss of physical ability, grief if anyone passes away in the fire and you're a survivor, loss of pets, body image concerns afterward, intimacy, whether that's due to body image or due to actual physical limitations that occur, other physical limitations, things like amputations or loss of mobility. Pain management is really important and can be difficult. Sleep impairment. This loss of autonomy is a big one too. I would say a high proportion of my patients are injured at work, so they're Workmans Comp cases. And a lot of very self-sufficient people who showed up, went to work all day, got the job done, their primary identity was their job, and now they're having somebody have to change their bandages and help them shower, and they can't move their body in the way that they're used to, and so that's a big loss. Psychiatric conditions that are common among burn patients. So acute stress disorder, which we all know is within the first month after the trauma, and then PTSD longer term, anxiety, depression, and then delirium in the ICU setting. So studies show that the rates of PTSD among burn patients are as high as 45%, and there is some evidence showing that the rates increase over time related to additional or subsequent repercussions from the traumatic event. So job loss, health problems that are longer term. So one study showing, or some longitudinal studies showing that about a third of burn patients develop PTSD within 2 years of the injury. And then there's this idea of chronic or continuous traumatic stress. So there's the index trauma, which is the fire, the explosion, and then being in the hospital itself can be pretty traumatic for people. So the dressing changes are incredibly painful. There's a lot of unknowns. There can be different medical interventions that are just really hard to cope with. And so it's almost like you keep getting re-traumatized. So when I'm doing prolonged exposure with patients, the index trauma we often think is, oh, it must be the fire, but sometimes certain things that happen during the hospitalization are actually more distressing to people versus that first traumatic event. So that's something to be mindful of as well. And pre-morbid psychopathology, like in a lot of different things, is going to be a risk factor for developing PTSD. Rates of depression can also be pretty high, up to 18% reporting depression within the 5 years post-burn. And the PTSD and depression symptoms are often highly comorbid. Studies show that the psychological distress can actually negatively impact physical recovery as well. So patients can, the pain can exacerbate the distress, and the distress can exacerbate the pain. Patients with higher psychological distress are less likely to engage regularly in rehab, which is so important to their recovery and to their long-term functioning. It can impair communication with providers, obviously decrease participation in enjoyable activities, disrupt sleep, and cause a lot of challenges in relationships because it's a huge adjustment. So this is why, again, psychology is so important with this patient population, because we really do have an opportunity to intervene across both medical and psychosocial outcomes. So I pulled this from an article where they really do a great job outlining how there are various recovery stages in terms of how severe burns are and as people are becoming alert. So throughout these stages, there are different ways and different needs of the patients. So we'll start with the resuscitative or critical stage, move on to the acute stage, and then into long-term rehab. In this first resuscitative or critical stage, patients are typically in the ICU, and really survival is the main focus. So they may be sedated, intubated, minimally alert. I have done some relaxation interventions with patients that are intubated, but usually there's not a lot of psychological intervention at this time. So you're really trying to help people protect the patient's coping strategies. Denial and repression are totally okay. Like, people are just trying to survive. You may provide education to family and then also to staff for things like behavioral techniques to maintain alertness during the day and to decrease likelihood of delirium. In the acute stage, patients are kind of coming off the sedation, so there's greater alertness and more awareness, especially of the painful procedures, which is when you see more of the depression symptoms coming in, a lot of heightened anxiety. You may see some of the acute stress symptoms, people reporting nightmares or other difficulty with sleep that are above and beyond the difficulty of sleeping in a hospital at baseline. And you also may see premorbid psychopathology become more apparent. So patients who have pre-existing personality disorders or panic symptoms, this may start to show in interactions with nursing staff or physicians. So this is often when the consults come in. The goals here are really focused on like brief intervention. So you're doing brief counseling, psychoeducation, retelling, relaxation training. So psychoeducation, a lot of times when I go in for the initial consult, patients are really, just to be frank, like freaked out because they're having nightmares or they can't stop thinking about what happened, and that's pretty scary to them. So what I try to do is a lot of normalizing of you're really in the early stages of this, and it's okay to be scared of what happened to you because it is scary and it was painful. So normalizing that, people think they're going crazy. We don't want that to be the case. Additionally, talk about like what is acute stress disorder, what is post-traumatic stress disorder. Sometimes you only get an opportunity for a couple meetings with these people, with these patients. So talking to them about what's normal and to be expected, and when, if it continues or if the severity worsens, they should reach out and how to go about doing that. Giving them an opportunity to talk about what happened can also be useful, but you want to let the patient guide this, because forced retelling or trauma processing, debriefing right after actually has some negative outcomes in the data, or in the literature. People can say that they like talking about it, but then later it actually can contribute to onset of PTSD. So you really let the patient guide whether or not they want to talk about specifically what happened, but potentially encouraging them to talk with family members or support systems about how they've been feeling. Additionally, relaxation training is great at this point, so incorporating breathing techniques, guided imagery, things like that can be useful. Psychopharmacology for anxiety, pain, sleeplessness, depression. As the health psychologist, I'm not prescribing. I would usually defer to our consult liaison psychiatry service, so I would tell the burn service that a patient is experiencing this level of symptoms and they may benefit from a medication evaluation, so then they'll consult them. This really isn't the time to address premorbid psychopathology. So this happens with a lot of different types of medical specialties when patients are in the hospital. A medical provider may see that they have a history of bipolar disorder or I mean, that's a common one that comes up, but other pre-existing issues, interpersonal issues, OCD, and then think, oh, we should consult psychiatry, or psychology. But we're not there to intervene on previous diagnoses. It's more of how are these concerns or symptoms impacting their functioning now and their ability to cope with what they're going through in the hospital. So you really want to focus on present moment concerns. During the acute stage, pain control is really important because, again, people are coming off of the intubation, they're decreasing sedation, and they want to get people more alert and active so that they can participate in therapies. So you have this procedural pain, which is when they're doing dressing changes or debridements, and patients are experiencing acute pain there, but then there's background pain related to just kind of always ongoing. So the treatment plan often includes pharmacology, things like opioids, lorazepam, gabapentin, and then incorporating non-pharmacological approaches like CBT, relaxation, breathing imagery, and the virtual reality. So this chart here is, or this graphic, excuse me, is talking about how it's difficult to get people in a window where their pain is well controlled, but they're also alert enough and to be mobile or to be engaged in physical therapy and occupational therapy. So it's definitely a difficult thing for providers to achieve because they don't want patients to be in pain, but they also don't want them to be totally sedated where they can't do anything because that will really interfere with their long-term physical recovery. So that's where some of these non-pharmacological approaches can be beneficial to tag on to some of the medical or medication interventions. And a lot of good data on relaxation and imagery. There's some really cool studies on using virtual reality with patients. So they'll put on the virtual reality goggles and have them do different kind of video game type things in snow or cold areas, and it's really helpful for during dressing changes to distract and cope with the pain. So a lot of interesting things there, and hopefully more research will continue to come out of that. Then we move into the long-term rehabilitation phase. Characteristics here, so a lot of the concerns are related to physical issues. After burns, as you're recovering, I mean, people have probably experienced with any minor injury. As things are healing, you itch. So if it's your whole body that's impacted, there can be a significant increase in itching. There can be nerve pain, so people have lingering shooting nerve pains, decreased endurance, and overall physical functioning, coping with recovery from amputation. The social concerns, like body image, sexual concerns, role changes, resuming work, and psychological, so specifically addressing the anxiety, depression, PTSD. I think what I see a lot, I mean, people are diagnosed when I'm seeing them outpatient, usually with PTSD, but the social piece is so important because people have a variety of reactions to having to talk about, one, the injuries, if it's a trauma, but also the idea of being hurt, the idea of being in the hospital for an extended period of time. People have all sorts of poor boundaries with patients when they say oh, can I see your scars? And these are patients who are barely looking at their scars themselves. And then at a party, somebody's like, oh, can I see your stomach? So a lot of our work is, in addition to trauma processing, working on what can be your elevator speech about what happened to you that kind of answers the question, but you don't have to get into detail. How can you respond to people effectively and shut down inappropriate requests, even without damaging the relationships? And then this resuming work, a lot of that goes into our treatment for PTSD too. Psychological interventions during this phase would be more so outpatient psychotherapy, social skills, training or support groups, and peer counseling or vocational counseling for people that may need to change jobs or get back into a new occupation. With Loyola has a monthly peer support group that's been running for years and has like a lot of survivors that attend. Our burn social worker hosts it, and people really seem to benefit from that exposure to other patients who have been through what they've been through, because people can say when they've been in a car accident or they've been through another trauma, but relating to another person that's been burned really helps people with their psychosocial recovery. All right. Okay, so let's go into my specific aspects about psychology and burn. So again, I did my as Zoe said at the beginning, I did my fellowship at Loyola, and Loyola's Health Psychology Fellowship is a good portion of psychosocial oncology with consults, but then you're also doing inpatient consults on the transplant services and general medicine services, kind of across medical specialties. And when I was hired on in my current job, it was supposed to be primarily bariatrics, so bariatric surgery, weight loss, and then outpatient work. And so I really wanted to make sure that I could do some more inpatient work. And Dr. Wool, my colleague at the time, was covering all of Gen Med, and burn fell under that. And she just would do it, but didn't love it. And so it was like, if you want to take that portion of it, go for it. And I'm telling you guys this because I know that many of you are in training and kind of carving out your own interests and specialties. And so it was a unique path to get here, but I'm so glad that it worked out. I wanted to work in a multidisciplinary team as well. And then I felt like the burn population had some of the areas that had been of focus for me throughout my training and then also in my fellowship. So adjustment to hospitalization, we see that again across medical specialties. I did a lot of trauma work during my internship at Jesse Brown. Much of my experience with disordered eating and weight management involves body image concerns, and then pain management, which I think I saw Dr. Cozio jump on here, but he was my supervisor for pain management at Jesse Brown. So I knew that I would be able to touch on all of these areas if I were to work with the burn service. The burn team, as it stands at Loyola, includes surgeons, multiple nurse practitioners, nurses. There's a specified pharmacist and physical and occupational therapist. There's also respiratory therapists because they're often needing intubation or supplemental oxygen, a specific dietitian. Burn recovery requires a lot of calories, and so patients are often on feeding tubes and getting a lot of supplemental nutrition. Chaplain services, and then myself. So what do I do as a health psychologist on the burn team? Inpatient is one of the primary roles. With inpatient consults, like I've been saying throughout, usually it's in that acute stage where patients' anxiety symptoms are starting to come out. Maybe they're more tearful or they're fearful of certain procedures. So the surgical team would call me to come meet with patients while they're there. PTSD screening, outpatient work, research, administrative, and future direction. So I'll go into these in more detail. Sorry, I'm jumping around here. With the inpatient work, when I was first trying to build up my service, and what that means is there was always psychology available, but when you want to be the health psychologist who's like part of the team, you have to be physically around. Because the idea of you is great, but then the full day passes, and if they need to call nephrology and they need to call PTOT, if they don't really know you or think of you, some of the psychosocial needs don't get addressed right away. So I went to rounds, and I loved that. You get to go in the morning and go with the team to every different patient room and talk about each patient, which would give the psychologist an opportunity to identify concerns and offer services or suggestions on the spot. And it helps you build relationships with the providers so they know who you are and they know who they're referring to when they call up the psychology consult. Then when the consults are placed, I get paged by the service. Again, common consults requests are anxiety redressing changes, some acute stress symptoms. Usually it'll be patients reporting nightmares or saying they can't stop thinking about what happened, and that would be a cause for concern. Sadness, lethargy, maybe they're not participating actively in their therapies, and some difficulties with pain control. So those would all be common reasons why they would call me up. When I would go, initially, I meet with the patient. I do a full psychosocial intake, so see what their experience has been like lately in the hospital and what happened leading up to the admission, and then doing a full history with regard to any prior psychopathology, substance abuse, and prior treatment so that we can identify what we would need going forward. Then there's follow-up during admission. So ideally, I like to see people weekly or twice weekly when they're there. Some of these patients are in the hospital for 4 days. Some of these patients are in the hospital for 2 to 3 months. So you can get a wide range of need and frequency. One of my patients I saw during his admission, he was in the hospital for, I want to say, just over 60 days. And on the burn unit, you wear a mask and full PPE even when there's not COVID. So when everybody was talking about going back to work in office and how it would be awkward with a mask, with your therapist, this guy was like, I met with you for 2 months with your mask on. That's all I know. So just interesting that the environment is different, but can definitely build relationships with people when they're there for a longer period of time. Doing a lot of coping skills work, again, psychoeducation. The development of the PTSD screening was something that went hand in hand with when I was starting to be more specified to the burn service at Loyola. They were also undergoing re-verification with ABA, and one of the things that was identified was increased screening for PTSD. What we did was choose a brief screener. This is called the Primary Care PTSD Screen, and that's the example of it to the right. It's 4 questions, and 3 or more yeses is positive. So what we did was create an EPIC build so that it could be entered directly into the medical record, and then a dot phrase that would pull whether or not the patient was screening positively, so the surgeons and nurse practitioners could pull that right into their note very easily. What happens is the service rep, the person checking them into the appointment, provides them with the paper that has the questions on there. Patient fills it out. Nurse enters it into the chart, and then the physician reviews whether or not patients are positive and adds that to the note. If they are positive, then our burn social worker is notified, and the 2 of us compiled a bunch of resources with psychoed materials on PTSD symptoms among burn patients, how to get help, what can be beneficial for people. And then she's doing the bulk of the work here, but she creates a location-specific referral list. Like I said before, there are certain burn specialty centers. So Loyola pulls patients from hours away. So when they're coming in for clinic visits after they've been discharged from the hospital, sometimes they're driving well over an hour to get to that visit. So it's just not something that would be super realistic for them to come weekly. And what we do is provide them with a location and insurance-specific list so that they're able to find providers who would see them for their needs closer to their home. If they are local, however, though, the provider places the order in EPIC, our medical record, and then that goes to our psychology scheduler, and they are scheduled with me for a further evaluation. Okay. In the initial visit when I'm seeing patients from the clinic, I usually do a few objective measures. The PCL-5 is the post-traumatic stress symptoms checklist for DSM-5. Oh, really quickly, let me go back to this PTSD is based off of DSM-4 criteria for PTSD, so it's only the 4 questions. There is an updated version for DSM-5. Unfortunately, we had created the EPIC build like right before the new version came out, so we just use this because it's a screen, it's not diagnostic, but eventually we'd like to change it to the DSM-5 version. So I do the PCL-5, I also do a PHQ-9 and a GAD-7 to assess depression and anxiety symptoms, then a full psychological intake with a lot of screening for PTSD criteria. So basically going through every part of the criteria and assessing whether or not patients are endorsing that. Then psychotherapy is usually weekly. I would say, anecdotally, out of the patients that get referred to me, probably 90% end up being positive, like actually having diagnosable PTSD symptoms or PTSD, as opposed to some patients just come in and they may have screened positively on the 4-question questionnaire, but they are more dealing with adjustment issues, or by the time they get scheduled 2 or 3 weeks later, the symptoms are already resolving, and so you're just doing additional psychoeducation about normalizing symptoms and then what to look out for if they need additional treatment. If they do meet criteria for PTSD or an additional psychiatric disorder, I would see them for weekly therapy. I'm often using prolonged exposure, ACT, and CBT. So prolonged exposure is a trauma-based intervention where patients are identifying an index trauma or the specific traumatic event and then engaging in what's called imaginal exposure, where they retell the narrative of the memory repeatedly, and then also engage in vivo or in life activities that remind them of the trauma or have been avoided since the trauma occurred. I like ACT with the burn population because there's a lot of things that like big changes that occur and things that are more permanent with regard to scarring, physical limitations. So clarifying values, helping people engage in activities that are meaningful to them, and accepting where they're at with regard to those changes. Okay, I mentioned this a little bit before, but I get a lot of Workman's Comp cases, and I had zero exposure to this before I started doing the burn work. So Workman's Comp means the patient was injured at work, so their work has a specific insurance that covers all their treatment related to that injury, which includes psychological treatment. Some of the challenges are you have to have really specified treatment plans, which we all do, but as you do more and more therapy, some of the things become more flexible with regard to timeline or expected duration of treatment, whereas with these Workman's Comp cases, a lot of times they'll want a predicted number of sessions. I've learned to err on the side of asking for extra because you want to make sure that they're not going to reject future requests for additional sessions. Some communication with case managers. So I've had patients where the case manager who does all the Workman's Comp coordination actually comes to the initial visit, wants to hear the diagnosis, wants to hear the symptoms that are leading to the diagnosis and the treatment plan. Sometimes that's on the spot, and so it can be a little anxiety-provoking at first, but it helps you really conceptualize and get your treatment plan in place right off the bat. Additional administrative tasks. So a lot of releases of information. They have to sign release forms to make sure that the Workmans Comp people can access their chart, get the notes, because they're not going to pay for the sessions unless they are knowing what you're doing in session. Letters, so usually every week I have to submit a letter for the patient in their chart saying that they still need to be off work, we're still in treatment, the frequency of treatment, and that is something that we usually print in the clinic. Lately, our admins have been doing a great job of scanning and emailing, so making it work. And then depositions. So I don't know if any of you have ever done depositions with your psych work, but I had not. And a lot of times patients are in, not a lot, but some of the times patients are involved in lawsuits if there was faulty equipment or something malfunctioned that caused the accident. There may be legal involvement, and you may be called to comment on the psychological distress sustained from the accident and then what you think in terms of their long-term recovery, which is nothing I had ever done before, but definitely an experience. The benefits of working with these patients for Workman's Comp are there's a higher level of motivation. So typically, the patients that I see really want to get back to work. Like, this is who they are, this is their identity, this is what they're good at, and so they don't like feeling this way with regard to the PTSD symptoms. And if you say you can help them, they are willing to show up. With my bariatric patients, there's a lot of ambivalence about proceeding with surgery, weight loss, and so it's a nice contrast. And then consistent attendance. So they have to come to their recommended medical appointments, whether that's physical therapy, follow-up at the burn clinic, and psychotherapy, or they will not get their check. So people show up, which is nice. Also in my job is the opportunity for research. It's not built in clinically, but we do a lot of things that map onto the clinical work that we're already doing. So we did a poster and presentation on the screening protocol that we implemented and how we designed and created that procedure within our outpatient clinic. Then looked at the data specifically that we found among patients who experienced or who endorsed positive PTSD symptoms on the screening. And then another one that I definitely wanted to mention, the PTSD symptoms secondary to intra-hospital course. So sometimes patients are treated with ketamine for analgesia, like for their pain control. And at different doses, ketamine can have hallucinations as side effects. So I started noticing that some of my patients were identifying their hallucinations from the ketamine as traumatic. So when we were doing the trauma therapy, they were noticing that the hallucinations were even more traumatic than the initial injury. So this is something that we just did a case series on and looked into these patients. But actually, over the years since I did that poster, I've had more patients talk about it. So it's definitely something that needs to continue to be addressed and something that we're looking at in terms of how is the ketamine administered and what's the environment in terms of, like, it's supposed to be quiet and calm and making sure that there aren't things that are going to exacerbate the negative side effects. But I've talked with some of my patients about how, again, for a long time, the goal was simply survival. And now, as people are surviving and living through these injuries, it's finding a balance between what's going to help them physically recover, but also preventing exacerbating psychosocial or psychological distress. Administrative work, we also do monthly quality improvement meetings and then research committee meetings, which is, again, just a big part of the multidisciplinary component of being a health psychologist, and so something that I really enjoyed. Additional directions. So I see only adults, and We also treat pediatric patients at Loyola. So that's an issue that's come up, is that there are teenagers, there are school-age kids who would benefit from psychological intervention, both in the hospital and immediately outpatient. There is a psychologist at Loyola who's a pediatric psychologist, but she basically gets any referral for a kid that's under 18, and so it can be hard to coordinate that. So ideally, we'd like to increase the availability of pediatric psychology. Also create in-clinic availability. So this is something that we were really getting closer to incorporating before COVID, but finding times for me to carve out portions of my schedule where I would actually be sitting in the burn clinic during busy clinic days with the surgical follow-ups and available on site. So right now, it's pretty smooth with regard to patients get screened for PTSD, social worker comes down, gives them resources, and then the order is placed for a follow-up. But it would be great if that same day I could come by and do my full intake and then provide recommendations and get patients scheduled so that they were meeting me on site, because sometimes people are lost to follow up from that initial, not because we lose track of them, but because, as I'm sure you've seen in different medical clinics, when patients are there for their medical appointment, they're kind of more open to psychology coming in and providing additional recommendations, as opposed to them saying, call this person, go back to another appointment. So getting them to come back can sometimes be harder to do. So that's one of my goals. Again, it's been hindered a bit over the last 6 months, but we'll work on it. And additional time for inpatient follow-up. I would love to be able to be available for relaxation training and intervention during dressing changes repeatedly or on a schedule, but my clinic schedule is really carved out to be primarily outpatient, and then I go see consults in the gaps that I have. So eventually I'd love to be able to have carved out time so that we can really make that more coordinated. I'd love to get back into rounds at 7 a.m. and just with my work-life balance these days, I haven't been able to make that work as frequently as I would like. Like I said, the collaborative care during dressing changes, and then multidisciplinary education for patient-centered care. So this is things like the ketamine procedural aspects of dressing changes, how to, our nurses are really great, but like additional provider education about making sure that they're screening for and reporting any psychological concerns that they are aware of, and things like that. So here are some references. I think we have some time for questions here, so let me try to end my slides. If I need to go back to it based on questions, I will, but I just want to make sure that I can see what I need to see. Okay. So do you want me to try to scroll up to the top and just go through?
So our first question is with Isha, just right there near the bottom.
Do you find it challenging to complete the intake in one visit with the patient, given that they may be in a lot of pain or on high doses of painkillers? Yes, that can be a concern. Something that I will clarify with the service, like the surgeons, it's more the residents that are the ones that are paging me, is the patient generally alert and able to engage, and do they consent to a psychology consult? So that's something that has just been what I've defined for my service is the patient aware that they've consulted psychology, and are they on board for that? So then that usually gives a little more buy-in and people are willing to talk. But if they are highly medicated or just got pain meds before a dressing change or finished physical therapy, then it may be something where I'm coming back a couple times to make sure I'm completing it in full. Okay. Are you assessing for acute stress disorder inpatient? This is from Dr. Schneider. And also, are you noticing any trends that the larger the TBSA does not necessarily warrant meeting full criteria for acute stress disorder, both inpatient, outpatient? And prior to starting at MedStar Washington Hospital Burn Center, the belief was the larger TBSA, the more likely acute stress disorder. Great questions. So yes, I'm assessing for acute stress disorder inpatient. So going over brief symptoms, checking for nightmares re-experiencing, sort of like hyperarousal, change in negative, like emotional affect and cognitions. But it's hard to say though, because even within the first, like we're screening for it and sometimes diagnosing it, but a lot of times the patients that I've seen inpatient are not meeting full criteria for acute stress disorder. A lot of times it's more of just acute anxiety or feeling like a sense of loss or coping with grief that may have occurred. More of the PTSD symptoms come with the patient's outpatient. And again, this is something that we've battled with. When I say we, I mean myself, the social worker, the team, is we want to screen for it because, again, it's so important in physical recovery and long-term outcomes, but we don't want to over-pathologize it either, because if you have nightmares after you just had a house fire, or if you can't stop thinking about the work accident that happened, like, that makes sense to me. And if that's distressing to you, it also makes sense to me. So I don't want to make it so, like, I want to intervene enough, but not to where people think, oh my gosh, this is never going to change, because there is a potential for recovery. So you want to buffer their natural coping skills and help with that as well. And then the TBSA question is great, because that's something that we found on our screening, is that the positives were not necessarily related to greater TBSA. I almost find it's like, and this is again completely anecdotal, but like the inverse, or not quite the inverse, but sometimes the people who have such high TBSA for some reason have like less significant distress about it, or greater radical acceptance potentially, because they've just like surrendered to this being their new life. So I think it's interesting to think about. All right, let's see. Okay, so related to Isha Kumar's question, do you find that pain medication can influence cognition of patients? I've observed brain fogginess for some pain-related patients at initial intake in medical settings. I'm curious how you approach that intake, considering the WITHIC cognitive level. Good question. I haven't had, I mean, I'll assess for what kind of pain medications patients are taking, and again, we always want to check for any misuse of pain medications, but I haven't had specific issues with brain fogginess per se. Something that I have noticed is, and this is in the literature as well, is there can be some cognitive effects of electrical injuries. I know Dr. Neil Pliskin does a lot of this work at UIC in neuropsych assessment of patients with electrical injuries, and whether or not they're standalone neurocognitive changes or if it's secondary to PTSD or depression. So not specifically, but I'm always assessing for doses of pain medication and how that might be impacting cognition. And then Dr. Schneider responded that they use a specific assessment. Great. Richmond Agitation Sedation Scale and Confusion Assessment method. Great. Okay, somebody said, I'm glad you brought up intervention during dressing changes. Could you speak to logistics mechanics of being in the room providing your intervention while other providers are working with the patient? What does this look like in your experience? So I will be in the room closer to like the side of the bed by the patient's head, and then they may be doing dressing changes like down below on their body as I'm guiding through a relaxation or a guided imagery script. And actually, this was one of my first patient encounters on the service independently. I had done some supervised consults during my fellowship, but I was asked to do some relaxation interventions with a patient who was intubated, but alert enough that was having some distress during dressing changes. And they came in, and it was a big TBSA. They just started taking everything apart and taking it off. And so this is when you're really like a medical psychologist. Like it's different than sitting in a room with a patient across the way, fully clothed. You're really in their like private, vulnerable state. And so you have to decide like what your comfort level is with that, and then define with the nursing team or the providers like what it will look like so that you're not in their way, both physically, and that you're able to provide a supportive intervention. That's helpful. Trying to see any other questions. Anything else that you guys noticed question-wise? Or does anybody have any other questions for the last couple minutes?
I have one question. So you mentioned near the beginning of your presentation that you kind of advocated for your own role in the burn unit, and that you have to be there in order to kind of have a presence and to build up that role. I'm just wondering if you could talk a little bit about how you did that and what that looks like over time.
Yeah, so I started with who I knew and where I could get buy-in. So that was social work, because Kelly, our social worker, has been with the burn service for, I want to say, like close to 10 years, and leads all the support groups and really knows the ins and outs of the psychosocial needs of patients. So she was a big advocate for an additional specialist, like a psychologist, that could address these needs. So met with her. Her idea was for me to go to rounds, to be present, to have them like see who I was, know what my availability was. And then you just slowly like integrate yourself. I met with the surgeons individually to see what their specific concerns were, or what I think you want to pitch it as what's going to make their job easier, because difficult patients who are refusing dressing changes, patients who are refusing physical therapy or occupational therapy, make it hard for the medical team. So I think coming at it from that angle of like knowing what's going to make the jobs for the team easier as well will help you have more buy-in and more leverage with people using your services, not only because they want to make their lives easier, but also because they do care about their patients' well-being and overall recovery. Any other questions today? All right. Well, if anyone has any questions or any interest in burns and would like to communicate further, I'm happy to talk further. Just let Dr. Katnese or the other Jesse Brown hosts know, and they can connect you with my contact information. But thank you so much for attending today and for having me.
That was
Thank you
great.
so much, Dr. Simmons.
Dr. Simmons.
Thank you.
Thank you. Have a great afternoon, everyone.